Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Arun Srivatsa. Dr. Srivatsa completed his undergraduate training at St. Joseph's College in Bangalore, India. He graduated from Bangalore Medical College. He completed his internal medicine residency as well as his gastroenterology fellowship at the University of Rochester Medical Center in Rochester, New York. Dr. Srivatsa is board certified in internal medicine and board eligible in gastroenterology.
All right, good afternoon. Some familiar faces in the audience, and welcome to everybody. So today's talk is going to be about colon cancer prevention and treatment. So I don't have any disclosures that are worth mentioning. What we're going to talk about today are facts and figures about cancers, including colon cancer, some risk factors that would be pertinent, and how colon cancer would present, what symptoms it has, how one would treat colon cancer, and finally, most importantly, how one can screen and prevent colon cancer and treat this cancer. So in 2014, about 800,000 men and 800,000 women probably developed cancer. These are estimated new cancer cases in 2014. And as you can see on the left-hand side in men, we have prostate being the number one most common cancer. And on the right-hand side, you have breast cancer in women being the most common. Then as you go down the list, you see that lung cancer is the second most common in both men and women. And colon cancer, which includes rectal cancer, is the third most common cancer in both men and women. So that's an important statistic. Next slide shows you the estimated people who probably died of cancer in 2014. And again, the number 3 on that list is colon cancer. So while it's not the number 1, it certainly is up there, and it affects both men and women equally. So in 2014, there were about 96,000 cases, new cases of colon cancer, 40,000 cases of rectal cancer, causing about 50,000 deaths. The good news, if I started off on a dark and morbid note, the good news is that the death rate from colon cancer is steadily declining, which is good. And this is mostly attributed to improved treatment and also improved screening and prevention, which is the basis of today's talk. This is another graph that shows you how cancer incidence rates have changed over the years. And as you can see, prostate cancer really took off in the 90s, probably related to screening and the use of the PSA test. And as you look at colon cancer and lung cancer, those rates are actually reducing, partly because people have stopped smoking, they've probably improved their lifestyle, but also importantly, we're screening for these and picking up precancerous conditions and treating them, therefore reducing the incidence rates of cancer. This is among men. And the same thing holds true for women. You see the number 1 killer, the breast cancer, still up there. Lung cancer is still on its maybe way down because women, the smoking rates haven't really caught up as with men. So there are still a significant chunk of women who still smoke and haven't quit smoking yet. So the lung cancer rate still hasn't reduced as significantly as the previous slide for men, where the lung cancer rate is reduced. But you see that colon cancer rates are steadily decreasing for women as well, probably because of increased screening and picking up precancerous conditions. Cancer deaths, you see the steep reduction in lung cancer deaths as smoking rates reduce, but you also see the steep reduction in the green line for colon cancer deaths. This is among men, and a similar statistic for women. Just a little side note there, in the box you have pancreatic cancer, which is not doing so well. Pancreatic cancer is still a pretty bad cancer to have, can cause a lot of morbidity and mortality. So let's go to California. In 2014, the estimation for new cancers of all sites was 171,000 new cases of cancer in California, out of which about 14,000 new cases of colon cancer were expected in 2014. So we don't want any of us to be amongst that statistic. And if you go to the next slide, the number of deaths attributed to cancer in California, 58,000. Attributed to colon cancer, 5,000. So that's a sobering statistic. There are some differences in ethnicities as well as sex in terms of cancer incidence rates. For reasons that are not very clear, black males have a higher incidence, so they're more statistically more prone to get colon cancer, as compared to white males, followed by white females, and lastly black females. But if you look at the death rates, again, black males seem to have a higher incidence of or a higher statistic of colon cancer mortality as opposed to other ethnicities. But the good news is, as we compare over time, treatment seems to be improving that statistic. So to go into that a little more, if you look at colon cancer survival rates, from 2003 onwards, there again is a slight difference between the races. And then if you go to the next slide, the overall risk of developing cancer, and this is an important statistic, so I'm just going to dwell on this slide a little. All sites, the chance of developing cancer for a man is 1 in 2. It's that simple. There's a 50% chance a man is going to develop some type of cancer during his lifetime. And the risk of developing colon cancer is 1 in 20. 1 in 20 men in this room is going to get colon cancer. 1 in 7 is going to get prostate cancer, but that's for another talk on another day. If you go to women, 1 in 3 chance that any woman might get cancer during her lifetime. Risk of getting breast cancer is 1 in 8 during her lifetime. The risk of colon cancer is again about 1 in 20. So similar statistics for both males and females. So if one compares the survival rates for colon cancer starting from 1975 onwards, there was a 50% chance you would survive colon cancer if you had it in the 70s. That statistic has improved to 65% in the first decade of this century. And it probably is higher right now. Right now, we don't have those statistics yet, but I'm pretty sure that as treatment improves, as screening improves, we're picking up cancers earlier, we're treating them better. So survival is improving. And that's a good statistic. All right, so the next part of the talk, we're going to talk about what are some of the risk factors for developing colon cancer. You see the yellow pie in this pie chart. The majority of colon cancer is sporadic, meaning there's no attributable cause. About 10 to 30% of the time, as noted in the light blue or teal section, there's a family history of colon cancer. So if you think that, hey, you know what, no one in my family ever had colon cancer, I'm fine, probably not true, because 65 to 85% of the time, there is no one in the family who's had colon cancer. The very rare genetic syndromes, familial adenomatous polyposis, and the other rare syndromes account for 1% or less of colon cancer. So given all that, what increases a person's risk? If you have had colon polyps before, as you grow older, so increasing age, if you have had inflammation in your bowels, known as inflammatory bowel disease, if you have had any other type of cancer, so you probably just carry a gene that promotes cancer in your body, or if someone in your family has had cancer. So those are the risk factors that are kind of ingrained or you cannot change. And then on the right-hand side, you have risk factors that you might be able to change, such as physical inactivity, being overweight or obese, smoking cigarettes or other products, and certain types of diets, which we'll get into more detail as we go along. You can also stratify cancer risk based on the type of polyp that is removed. Certain polyps, called as tubular adenomas, are called precancerous. But even in a tubular adenoma, the risk of cancer goes up as the size of that polyp increases. So as that polyp grows, the risk may go from 1% all the way to 35%. The second type of polyp that is precancerous is a tubulovillous adenoma, which is a little more precancerous. Risk goes up from 3.9% in small tubulovillous polyps all the way to 45% in polyps greater than 2 centimeters. And the most precancerous type is a villous adenoma, which carries a risk between 10% to 50%. So what is a polyp? So this is a kind of a line diagram to show you the normal epithelium on the left side, and then all the mutations that occur to form a hyperproliferative epithelium to an early adenoma, and then you have intermediate and late adenomas, by which time they are precancerous. And from that late adenoma stage, it doesn't take much to form cancer. So basically what you're seeing is different mutations occurring in the lining of your colon to form a polyp, which is already precancerous and has very few steps before it turns into cancer. This is a pretty blurry diagram. I apologize for that. But what it shows you is the death rate based on the age at diagnosis. So the younger one is, the more healthy presumably one is. And really, the survival is much better when you're diagnosed early on as opposed to later on in life. But this statistic is from 2006. And with advances in surgery, colon cancer now is a highly treatable disease with a very good survival rate. But it helps if you're younger when you're diagnosed. Let's talk a little bit about the risk of getting colon cancer based on your family members. If you have no family members with colon cancer, that's good. You still have a 2% risk. If you have one family member, it's a 6% risk. And then it goes on till, if you have a mutation that is a genetic syndrome, you have a 70% risk, and that genetic syndrome is called HNPCC. We'll get into a little bit more detail of that. So going back to another way of showing that risk, the general population, 5% risk. So that's about 1 in 20 to get colon cancer. If you've had polyps before, your risk goes up a little bit to 15 to 20%, which is why you need colonoscopies a little more frequently if you've had colon polyps. If you've had inflammatory bowel disease, it may be as high as 40%. So people who have had ulcerative colitis, for example, and they've had it for a long time, they need colonoscopies even more frequently than the average person out there. And then if you have those genetic mutations, multiple family members with colon cancer, your risk is very high to almost certain that you will have colon cancer. Certain diets can decrease your risk, such as increased fiber, such as in vegetables, fruits, taking antioxidants, calcium, adequate calcium, and certain B vitamins such as folic acid. Certain diets increase your risk, such as smoked red meats, high percentage of animal or saturated fats in your diet, lots of refined carbohydrates, and consuming excess alcohol. So how does colon cancer present? What are the symptoms that one might expect? First of all, right off the bat, colon cancer may not have any symptoms in its early stage. Especially the precancerous stage of polyps may have no symptoms at all. You may be completely normal and you may have 2 polyps in you. But as those polyps grow bigger, usually they bleed or they start obstructing your colon, and then they start giving rise to symptoms. So if they're in the rectum, which is pretty close down to the anal canal, you may have bleeding 60% of the time, and you may have a change in your bowel habits 80% of the time. If the cancer is a little higher up in the left colon, you may have bleeding, pain, or you may actually feel a lump. Right-sided lesions, which are close to the appendix, present pretty late. Usually they're present with pain or a palpable mass-like lesion. They may cause bleeding about 20% of the time. But in any case, you see most of these symptoms are pretty nonspecific. They can occur with hemorrhoids. They can occur with diverticulosis. They can occur with food poisoning. I mean, these symptoms are not specific for colon cancer. Colon cancer can occur pretty much anywhere in the large intestine. It can occur close to the anus or rectum. It can occur in the part of the colon that takes a bend known as the sigmoid colon, the descending colon, the transverse colon, the cecum. It can occur all over the place. It doesn't matter where exactly it occurs. The treatment is usually more or less pretty similar. This is a graph showing you the stage at which colon cancer is usually diagnosed. Right now, about 40% of the time, which is the pie on the right-hand side of the graph, about 40% of the time colon cancer is localized, and about 20% of the time it is already spread, which is known as metastasis. There's distant metastasis to the lung, liver, or brain. About 37% of the time it is spread to the lymph nodes, but not beyond the lymph nodes. So we'll go into that a little more in detail as we move along the talk. So we determine the stage based on, first of all, the colonoscopy itself, but also with a PET scan and some blood tests for a tumor marker known as a CEA. So these are the stages of colon cancer. We have stage 0 towards the left, where the cancer is confined to the inner lining of the large intestine. Stage 1, where it has crossed the inner lining. Stage 2, where it's involving the muscle of the large intestine. Stage 3, where it might have gone up till the lymph node. And stage 4, where it's widely spread throughout the body. And as you can see, the bigger the cancer grows, usually the more deeper it can travel and the more distantly it can spread. So size is important, and so is time. The earlier we catch it, the better we have a chance of treating this. So the liver, the lung, and the brain are usually the sites the cancer can go to. It can also go to your bones. And the principles of managing colon cancer are usually to first get it out. The first thing we try and do is to have a surgeon take a look at this and try and excise that part of your intestine and try and get negative margins, meaning healthy tissue surrounding the tumor. The next objective of surgery is to get any lymph nodes that might have been affected and to avoid any spillage of the tumor. After that, we see if the tumor has actually spread to distant sites like the lung, liver, or brain, and then we start treating those with targeted treatments. So typically for stage 1, surgery is adequate and cures the disease. For stage 2, you may need some additional chemotherapy. For stage 3, usually you get chemotherapy before and after surgery. For stage 4, there may be a variety of options, including surgery or no surgery, but just chemo, sometimes radiation. Rectal cancer usually involves some radiation because it's close enough that it can be radiated safely. minimally invasive surgery has greatly improved survival rates for colon cancer. And those rates that I showed you have likely improved, although we don't have data for this decade. But we've had elderly folks with colon cancer treated well with surgery. The benefit of minimally invasive surgery is smaller incisions, less pain, and a shorter length of stay. So let's get down to screening. So screening refers to how we can prevent colon cancer by looking at a large section of the population and saying, do you have any risk factors? Do you have any precancerous lesions? Can these be removed? And therefore, can we prevent colon cancer? Or can we start treating it earlier than it would have otherwise manifested with symptoms? There are a lot of misconceptions and ignorance about screening, which is why we have talks about colon cancer screening pretty often. The most important recommendation is your own primary doctor's recommendation. Usually we see that if your primary doctor says, go get your colonoscopy, usually most people want to listen. They feel bad, they feel ashamed that they have not gone through with that recommendation. So talk to your doctor about this. Talk to them, see if you need a colonoscopy, and follow their recommendation. So why don't we talk about colonoscopies? We talk about Disneyland, we talk about winning the lottery. We don't talk about, did you get your colonoscopy? So it's an uncomfortable topic. Most people are unaware that they have risk factors, including their age. Most people don't see a doctor if they feel healthy. And there's also this fear of getting tested. Some misconception that it might be just a man's disease. And I think the most important thing is colon cancer really has no symptoms early on. And one feels that if I don't have any symptoms, I really shouldn't be having any precancerous stuff going on in there. But the embarrassment and fear might be too costly if we don't follow through with these screening recommendations. So who should get tested? So the American Cancer Society recommends all average risk men and women begin screening at age 50. So that's general guideline. And this is what a colonoscopy is, if people don't really know what this means. So we're looking at the large intestine, and what it entails is a small fiber optic tube which is flexible, which has a camera. It also has certain other ports through which you can put instruments to remove polyps and suction those polyps out. So it's inserted painlessly because it's done under sedation. So for most people it's a 20 or 30 minute procedure. You're sedated going in, you're sedated coming out, and usually there's no pain during or after the test. It involves a half a day off from work. And on the bottom right-hand side, you see the picture you get when you look through a colonoscopy. You see the high-definition picture you get of the insides of your colon. Here's a polyp. On the lower right-hand side, you can see an actual polyp being removed. The schematic shows how you lasso the stalk of the polyp, and then you can either cut that off with a snare or you can cauterize it and then retrieve it, usually through the channel of the scope. And this is painless because the colon is usually pain insensitive. It's one of your deep organs, so there's usually no pain when you remove this polyp. So what about the costs of screening? So the healthcare environment has changed rapidly over the past few years. Most people have higher deductibles, but screening for colon cancer usually is termed preventive, especially for people over the age of 50, and if it's done every 7 or 10 years. But then if you do have a deductible or a copay or a coinsurance, that might apply, especially in a PPO plan, especially if you're younger than 50 or younger than 40. In the third bullet, we mentioned that if biopsies are taken or polyps removed, then you may get a separate bill from the laboratory that's handling the specimen. And we're lobbying Washington, D.C. to see if all this can still be covered as preventive, because right now it's preventive if we don't find anything. But if you find a polyp, for mysterious reasons, it changes to a diagnostic test. So if you're under age 50, or you've had a recent colonoscopy, or we find a polyp and remove it, your insurance company may bill you as a diagnostic test. And then it depends whether you have an HMO plan or a PPO plan as to how much you're liable to pay for this. So screening has its costs and is recommended to start at age 50 for everyone, or start at age 40 if you've had anyone with cancer in your family. You either start at age 40 or you start 10 years earlier than that family member's age at diagnosis. So if that family member was 46 when he had cancer, you should actually start at 36. And then if there's genetic issues and you're part of a family that has familial adenomatous polyposis or Lynch syndrome, you'd really start at a much earlier age. So are people getting tested? So unfortunately, testing rates remain far too low. Less than half of all Americans at age 50 have had any form of screening for colon cancer. And I'm hoping that statistic is going to improve as we speak to the public more and more about this. So because of this, as we mentioned in a previous graph, only 39% of colon cancer is detected at the earliest, most treatable stage. If it's stage 1 or stage 2, the survival rates are almost 95 or 99%. And these are 5-year and 10-year survival rates. So it's good to find this cancer early because it's almost completely curable. There are some ethnic differences also in people who have been screened or have not been screened. We're not entirely sure what the reasons are, but as you can see, 67% of the Hispanic population at age 50 has not had a colonoscopy, 55% of blacks, 47% of Caucasians, 60% of people who have never been married, because usually it's the spouse who tells you, hey, you know what, you're 50, you need to go get your colonoscopy. Education levels also influence this because the more educated you are about this disease, the more likely you are to go get that test done. So why aren't people getting tested? One common reason we hear is, my doctor never talked to me about it. So talk to your doctor about it. Ask them if you need screening for colon cancer. So apart from a colonoscopy, there are some other tests that are being developed. We get asked a lot about virtual colonoscopy. This is a diagram of a virtual colonoscopy. Basically, it's a CT scan image of your colon that's reconstructed in a 3D fashion. So you use a very fast CT to generate 3D images. But unfortunately, you still need to clean your bowel. So you need to take the prep. And then you make your appointment with the CT scan machine, and they still insert a tube, and they distend the intestine with air. So it's pretty much like a colonoscopy, but you're not getting sedated in the CT scan machine. It's not endorsed and it's not paid for by insurance companies for colon cancer screening, mainly because of the cost. So these are images of what you get from a virtual colonoscopy. So there's some expense involved in generating this image using a CT scan. And as you can see, there are 3 slices taken, and then they're reconstructed to form a 3D image. And there you can see a polyp in the lower right-hand corner. But once you generate that image, which is usually done by the computer later that evening, and then the physician, the radiologist, reads it the next day usually. By that time, you've gone home, and they tell you, you know what, you have a polyp. Now you need to go get your colonoscopy. And then you've got to go through that bowel prep again. So it had a lot of interest a few years ago. Right now, Medicare and most insurance companies don't pay for this. The main reason being it does not allow for therapy. If you have a polyp, you need a colonoscopy to remove that polyp. Apart from that, there's the radiation exposure. A CT scan done this way gives you a lot of radiation. And you're trying to prevent a cancer, but you're inducing a lot of radiation. So it really doesn't make much sense. This is a cartoon showing stool DNA. So if there's a polyp, it's shedding its DNA, which is abnormal DNA, into the stool. So a stool specimen can be collected, and you could test for all those mutations that occur in colon polyps. So this is available in certain areas. It will test to see if you have a polyp. But if you do have a polyp, again, you need that colonoscopy. So there's really no getting around having that colonoscopy done. There's also been some news about video capsule colonoscopies where you swallow a camera in a pill. Again, there's not much data available, and you still need to clean out. For that battery to see, for that camera to see polyps, you'll have to take your colon prep. And my view is once you've cleaned out using a colon prep, you'd rather get sedated and get a colonoscopy rather than go back again and repeating it all over again. All right, so another table showing you 5-year survival rates. And the most important statistic right up there, stage 1, early diagnosis, 93% survival. And this is from the past decade. As I said, this number continues to improve as better surgery and better techniques evolve. Again, the bottom of that table, stage 4, distant metastasis, less than 10% survival. So the key is catching this disease early, catching it at a precancerous stage, and preventing it. How can we reduce risk? So apart from following those testing guidelines, ask about your family history. There are a lot of people who come in, they haven't had contact with their family members. Get regular exercise. Avoid being overweight and obese. Avoid smoking, tobacco and other products. And avoid excess alcohol consumption. In terms of diet, 5 servings of fruits and vegetables a day has been shown to be useful in reducing a variety of health conditions, risks for developing heart attacks and strokes, as well as cancer. Choosing whole grain rather than refined sugars. Limiting intake of red meat to guidelines, and again, maintaining a healthy weight. So to summarize, to prevent colon cancer, talk to your doctor, see if you need a colonoscopy, get tested, usually starting at age 50, and encourage, once you've had your test, encourage your friends, family, and coworkers, because most people, once they've had a colonoscopy, they're pleasantly surprised as to how painless, how hassle-free that was, because it's really evolved into what was a more cumbersome, uncomfortable procedure to something that really just involves a half day off from your schedule and a little bit of a diet and a colon prep the day before. Maintaining a healthy lifestyle helps. So some take-home messages. Incidence and death rates are steadily improving as techniques and medicine evolves. Certain things reduce your risk, like eating right, exercising, and avoiding smoking. Screening for colon cancer saves lives, so go ahead and get screened. And most people do get screened if their doctor tells them to. And advances in treatment and advances in molecular targeting of cancer has really changed survival and improved things far beyond what it used to be in the 70s, 80s, and 90s. Thank you.